Glaucoma is the leading cause of irreversible blindness, and cases continue to grow year on year. Most anti-glaucoma medications in multi-dose bottles contain preservatives, which could cause ocular surface disease that leads to deleterious outcomes such as reduced quality of life, reduced adherence to treatment, increased rate of surgical failure and medication-related morbidity. But with Sunten's preservative-free glaucoma treatment, you could be the guiding star in your patient's journey. Start preservative-free therapy for naive patients who react badly to treatments with preservatives, or younger patients who require long-term treatment. Alter treatment by switching to preservative-free treatment for patients intolerant to OSD or have uncontrolled IOP under a monotherapy regimen. Replace treatment for pre-surgical patients to reduce risk of OSD and reduce surgical failure rate. Sunten's preservative-free tafluprost and preservative-free tafluprost timolol fixed combination effectively controls IOP with high response rate, high tolerability, and reduced risk of OSD, making the treatment more comfortable and improving the quality of your patient's life.
Vision is of critical importance. If you are not conscious of it, you cannot truly appreciate it. In fact, our world is built on the ability to see. Signs canvas the landscape of our cities. Vision is the integral infrastructure of our livelihoods, not to mention various sports or countless works of art. Everything relies on our ability to see. What is more, our daily lives, our work, our children's education, our ability to prosper at every stage of life depends on vision. And yet, it remains a fact that far too many people in the world today still are unable to see. Of the world's current population, there are 2.6 billion with myopia, 1.8 billion with presbyopia, 196 million with age-related macular degeneration, 146 million with diabetic retinopathy, and 76 million with glaucoma. And of those billions of people, at least 2.2 billion are disabled by their vision impairment. Further, of those 2.2 billion who have such difficulties, over 1 billion are not being treated or have illnesses that could have been prevented. Impediments to proper vision is a major social issue people around the world want solved. From 2030 to 2040, the number of eye diseases and disorders is expected to increase with the aging of the population, in addition to continued economic development centering on Asia. It is feared that even more people will suffer from vision problems, such as ones stemming from lifestyle diseases, as well as eye stress and myopia caused by the use of digital devices. At the same time, significant changes are expected in the healthcare industry. More individually customized services, growing interest in health and wellness, advancements in AI, IoT, and automation and other technologies, creating innovative treatments such as cell therapies, gene therapies, electronic devices, etc. In these times of great change in our society, precisely because of Sunten's focus on eyes, by bringing together a variety of strengths, characteristics, and technologies from around the world, Santen can contribute to society.
Painful, irritating, frustrating. What causes dry eyes? Our eyes are lubricated, hydrated, and protected by a fluid layer referred to as tear film. This tear film on the ocular surface is composed of two layers, the outer lipid layer and the muco-aqueous layer. The lipids prevent evaporation, while the mucus components stabilize the water molecules to form a gel-like property, lubricates the ocular surface, and clears debris. All elements have a role in achieving tear film stability. Eyes get dry when this becomes unstable. There are three types of instability. Aqueous deficient dry eye is caused when aqueous components decrease and the tear film layer becomes incompletely established with very unstable tear film. Increased evaporation dry eye is caused by insufficient or poor quality lipids, resulting in an unstable tear film. The third type is decreased wettability dry eye. A deficiency of membrane-associated mucin decreases wettability of the eye, contributing to tear film instability and shortened breakup time. All three can lead to dry eye disease. Symptoms include dry eyes, irritation, discharge, redness, and eye fatigue. Tear film instability is a core mechanism in dry eye disease. So, how can you regain tear film stability for your patients? Santen has a solution.
Glaucoma is the leading cause of irreversible blindness, and cases continue to grow year on year. Most anti-glaucoma medications in multi-dose bottles contain preservatives, which could cause ocular surface disease that leads to deleterious outcomes such as reduced quality of life, reduced adherence to treatment, increased rate of surgical failure, and medication-related morbidity. But with Santen's preservative-free glaucoma treatment, you could be the guiding star in your patient's journey. Start preservative-free therapy for naive patients who react badly to treatments with preservatives, or younger patients who require long-term treatment. Alter treatment by switching to preservative-free treatment for patients intolerant to OSD or have uncontrolled IOP under a monotherapy regimen. Replace treatment for pre-surgical patients to reduce risk of OSD and reduce surgical failure rate. Santen's preservative-free tafluprost and preservative-free tafluprost timolol fixed combination effectively controls IOP with high response rate, high tolerability, and reduced risk of OSD, making the treatment more comfortable and improving the quality of your patient's life.
Vision is of critical importance. If you are not conscious of it, you cannot truly appreciate it. In fact, our world is built on the ability to see. Signs canvas the landscape of our cities. Vision is the integral infrastructure of our livelihoods, not to mention various sports or countless works of art. Everything relies on our ability to see. What is more, our daily lives, our work, our children's education, our ability to prosper at every stage of life depends on vision. And yet, it remains a fact that far too many people in the world today still are unable to see. Of the world's current population, there are 2.6 billion with myopia. 1.8 billion with presbyopia, 196 million with age-related macular degeneration, 146 million with diabetic retinopathy, and 76 million with glaucoma. And of those billions of people, at least 2.2 billion are disabled by their vision impairment. Further, of those 2.2 billion who have such difficulties, over 1 billion are not being treated or have illnesses that could have been prevented. Impediments to proper vision is a major social issue people around the world want solved. From 2030 to 2040, the number of eye diseases and disorders is expected to increase with the aging of the population, in addition to continued economic development centering on Asia. It is feared that even more people will suffer from vision problems, such as ones stemming from lifestyle diseases, as well as eye stress and myopia caused by the use of digital devices. At the same time, significant changes are expected in the healthcare industry. More individually customized services, growing interest in health and wellness, advancements in AI, IoT, and automation and other technologies, creating innovative treatments such as cell therapies, gene therapies, electronic devices, etc. In these times of great change in our society, precisely because of Santen's focus on eyes, by bringing together a variety of strengths, characteristics, and technologies from around the world, Santen can contribute to society.
Painful, irritating, frustrating. What causes dry eyes? Our eyes are lubricated, hydrated, and protected by a fluid layer referred to as tear film. This tear film on the ocular muco-aqueous layer. The lipids prevent evaporation, while the mucus components stabilize the water molecules to form a gel-like property, lubricates the ocular surface, and clears debris. All elements have a role in achieving tear film stability. Eyes get dry when this becomes unstable. There are 3 types of instability. Aqueous deficient dry eye is caused when aqueous components decrease and the tear film layer becomes incompletely established with very unstable tear film. Increased evaporation dry eye is caused by insufficient or poor quality lipids, resulting in an unstable tear film. The third type is decreased wettability dry eye. A deficiency of membrane-associated mucin decreases wettability of the eye, contributing to tear film instability and shortened breakup time. All 3 can lead to dry eye disease. Symptoms include dry eyes, irritation, discharge, redness, and eye fatigue. Tear film instability is a core mechanism in dry eye disease. So, how can you regain tear film stability for your patients? Santen has a solution.
Hi, good afternoon, everyone. It's that time of the week again, and you know what that means, right? It's time for another ITV episode. So it is my pleasure to welcome you today to episode 23 of TMC ITV. This is Marga Mejia, and this episode is in partnership with Santen. So our episode today will focus on theory and practice regarding dry eye diagnosis and management. We will discuss the backbone of dry eye management and have some hands-on practice in terms of diagnosing and treating our dry eye patients. We hope that this will be a very educational refresher episode on dry eyes for everyone. So before we go further, let us begin our program by hearing from the marketing head of Santen Philippines, Miss Jennifer Ramirez for her opening remarks.
Good evening to all the participants who are watching tonight's program. This is Jennifer Ramirez, Head of Marketing from Santen. On behalf of Santen, we humbly acknowledge and thank the Medical City Eye and Vision Institute, headed by its director, Dr. Victor Caparas, its consultant, affiliated members, and residents of this prestigious institution for this great opportunity to sponsor yet another one of their longest running virtual educational platform, the TMC ITV, with episode 22 entitled Principles of Dry Eye Management. So thank you for your continued trust in Santen. Special thanks as well to our guest speaker for tonight, all the way from Seoul, Korea, Professor Jun from Yonsei University, for a comprehensive discussion of on the importance of diagnosing patients accurately and crafting a treatment plan to consider tiquafosol as the backbone treatment of dry eye management. We hope you found the topic to be an enlightening lecture, one that would increase your confidence in choosing tiquafosol for different patient types. We would also like to thank and acknowledge Dr. Keisha Duyonko and Dr. Christina Tan, who shared a very methodical workshop and case sharing on PFOD and PFOD concept to emphasize the importance and its familiarity of accurate dry eye disease diagnosis. So at this moment, we would like to strengthen our commitment to support the Philippine ophthalmology community by continuously partnering with the medical thought leaders and experts for more stimulating topics, if only to support your continuing medical development, as well as, help contribute to giving your patients the best vision experience while delivering happiness with vision. So thank you and enjoy the rest of the evening.
Thank you, Miss Jen, for that warm welcome. And again, thank you to Santen for teaming up with us to offer our viewers a segment that would be relevant to the times. Again, I would like to remind our viewers that this mini series is still part of our annual refresher course for dry eye management. As one of the centers in the country which offers an extensive arsenal for dry eye diagnosis and management, it is fitting that we highlight and make simple the different approaches to this disease. So, to discuss the backbone of dry eye management, we have a distinguished guest for today, who currently is an assistant professor in ophthalmology at the Severance Hospital, Yonsei University College of Medicine in Seoul, Korea, where he also did his residency and fellowship training. He did his PhD in pharmacology in Yonsei University in 2017. He has also won numerous awards and distinction the past few years, some of which include the Yuhan Prize for Medicine given by the Seoul Medical Association just last year, the Koo Bon Sul Academic Award given by the Korean Ophthalmological Society in 2018, and the Academic Award given to him by the Seoul Medical Association last 2017. He is the author and co-author of numerous publications and researches covering the fields of refractive surgery, cataract, cornea, and external diseases, including dry eyes. So, without further ado, let us welcome our speaker for today, Professor Ik Yun Jun.
Hello, everyone. Thank you for having me in this TMC ITV, and I'm also thanks to Santen for supporting this meeting. It's a great honor to be here and giving a lecture to you. As introduced, I'm Ik Hyun-jung from Yonsei University, College of Medicine, Seoul, South Korea, and today's my topic is about the diquaphosphor. Let me share my presentation. Okay. Today, I will discuss about the diquaphosphor can be used as a backbone of dry management. In 2017, the second revision of the dry definition was made by Deuce. It's Deuce 2 revised the definition. Deuce defines dry eye as a multifactorial disease of the ocular surface and contains loss of homeostasis of the tear film and accompanied by ocular symptoms, and in which tear film instability and hyperosmolality and ocular surface inflammation and damage and neurosensory abnormalities play an important etiological roles. Comparing with previous version, phrase loss of homeostasis and neurosensory abnormalities as an etiological role were added in this second version. Advances in our understanding of the risk factors and etiology and pathophysiology of dry eye made an evolution in dry eye management strategies. And in this Deuce 2, the importance of albumin gland dysfunction was highlighted. As I told you before, dry eye is a multifactorial disease. These factors are all related to dry eye and may act as a risk factor. Autoimmune disease and systemic drugs, and also the ocular and eyelid surgery also can affect dry eye. And the ocular and preservatives in eye drops and allergic condition and wearing contact lens and dry environments are also all the risk factors. This is the pathogenesis of dry eye, which announced the Deuce 2 report. In this figure, important thing is vicious cycle. Tear film instability can be arised due to various factors, and then the tear hyposomorality and ocular surface damage and inflammation develop. And low lacrimal secretion also influence on this vicious cycle. Therefore, to treat dry eye efficiently, we need to break the vicious cycle as this figure. Blocking a certain point is very important. So we can treat certain main points such as inflammation, meibomian gland dysfunction, and tear hyposecretion, and other things. Each detailed treatment options will be covered later. Under the Deuce 2 guidelines, dry eye can be diagnosed and classified through these processes in this figure. At first, begin with the assessment of symptom, and then review for signs of ocular surface disease. And if the patients have no symptoms and no signs, it is normal patient, not the patient. It's normal. And if the patient has symptoms and signs of ocular surface disease, and with the triaging questions and ancillary testing can be applied to distinguish dry eye from other ocular surface disease. As you can see in this right flow, symptomatic patients without demonstrable clinical signs do not fall into the dry eye disease group. Instead, They are differentiated into preclinical dry or neuropathic pain. It's not an ocular surface disease. Conversely, the asymptomatic patients with the exhibiting signs are differentiated into pre-dry eye or neurotropic conditions. In this neurotropic condition, management of dry eye is necessary. However, treatment for pre-dry eye patients is applied in special cases, such as before surgery. And this is the diagnostic algorithm presented by these two. If a patient has symptoms on dry eye and also has signs together, we can diagnose the patient as dry eye syndrome. After that, treatment method is determined by checking the type and the severity. And recently, new dry eye diagnostic algorithm was announced by OSID Expert Working Group in 2020, and it was supported by Santen. This algorithm also recommended that the patient's symptoms and signs are checked for dry eye diagnosis, and each types of dry eye should be assessed for optimal treatment. The types includes aqueous deficiency, decreased wettability type, MGD, and inflammation. And next thing is tear film. Tear film consists of a lipid layer, aqueous layer, and mucin layer, and it covers the ocular surface. The components of the tear film interact to maintain stability of the tear film, and it protects ocular surface. Among them, interest in mucin has been less than that of aqueous layer or lipid layer. However, mucin also plays a very important role. Mucin is heavily glycosylated glycoproteins, and there are two forms of mucin. One is membrane-bound form and one is a secreted form. The function of mucin is tissue coating, lubrication, and barrier function. In tear film, mucin enhances tear adherence to the ocular surface and facilitates tear spreading and lubricates ocular surface, and also acts as a barrier to pathogen and signal transduction. Again, key roles of ocular surface mucin is increased wettability and lubrication and barrier function. Barrier function occurs by trapping and removing the pathogens and debris from ocular surface. Accepting the importance of mucin, the Asia Dry Eye Society recently announced a new dry eye classification. In addition to traditional aqueous deficient type and evaporative type, they added the decreased wettability type. This is related to mucin. And also, the Asia Dry Eye Society emphasized tear film instability as the pivotal mechanism of dry eye. Causes of dry eye instability include abnormality in lipid components and decrease in mucin and water. Tear film instability makes tear film breakup, like this figure, and the risk factor affecting tear film instability is aging and reflective surgery and so on. And there are important factors to consider when treating dry eye syndrome. First is integrative approach should be taken in treating patients with dry eye syndrome. And the patient should be closely monitored for symptoms and meibomian gland shape and function and tear production. And it is essential to make an accurate diagnosis in order to formulate a treatment plan for the patient. Basic strategies of dry eye management are stepwise management and subtype-based management. By examining the patient, subtype should be divided, and subtype-based management should be performed by identifying which parts are bad for the actual patients and treating them. and stepwise treatment is required according to the severity of the patients. Stepwise treatment is to divide the level according to the severity of the patients and apply the treatment according to each level. Let's check the treatment for each level and step one by one. In step 1, the severity is low. In this step, just educate the patients about the disease and identifying the offending medications is important, and modify the environment of the patient is very helpful. And ocular lubricants like artificial tear can be applied, and in meibomian gland dysfunction patient, lid hygiene is necessary. And next, step 2. Step 2 often requires additional treatment. It is recommended to use preservative-free topical eye drops because preservatives can adversely affect the eye. And if the patients have MGD, lipid flow, and IPL treatments are very helpful. And topical drugs, including antibiotics, steroid, and cyclosporine, can be used. And also topical secretagogues such as diquaphosphor are also applicable. In step 3, oral secretagogues such as Salagen and Pilogen can be applied, and autologous serum and therapeutic contact lens can be another options. In step 4, it is very severe dry eye type. In these patients, we can use topical steroid for a long time, and surgical approaches can be considered. And second important strategy for dry management is subtype-based treatment. According to cause of the dry eye, treatment can be applied differently. In aqueous deficiency patients, tear substitute and tear conservation can be the main therapy. However, the MGD patients, lid hygiene and IPL or lipid flow can be a main option. Also, in mixed patients, both treatments should be applied. So, subtype diagnosis has a significant meaning to select the drugs and therapy. And many patients suffer from variable combinations of MGD and tear underproduction. This is a summary of treatment options according to the causes of dry eye. In tear insufficiency, tear supplementation using artificial tear is a basic treatment, and biological tear substitute serum can be used. And tear secretion stimulation using aqueous and mucin secretagogues is also important treatment, and tear retention using punctal occlusion is also applicable. In inflammatory dry patients, steroid and then antibiotics and LFA1 antagonist, which is Xiidra, can be used. And in MGD patients, lid hygiene, warm compression is a principal therapy. And in more than moderate MGD, lipid flow or IPL can be considered. This is another summary of subtype-based treatment, which is tear film-oriented therapy, aka TFA. It is a treatment that is customized according to each damaged tear film layer. In this figure, you can find diquaphosphor as a multiplayer for managing dry eye. Let's move on to the next topic of diquaphosphor. Diquaphosphor is a P2Y2 receptor agonist. P2Y2 receptor is one of the purinergic receptor and G protein coupled receptor. It can be activated by ATP or UTP. And the diquaphosphor has similar conformation to activate P2Y2 receptor. When P2Y2 receptor is activated, the calcium concentrations increases and various cellular processes start. P2Y2 receptor is expressed in a variety of ocular tissues, including corneal and conjunctival epithelium and goblet cells, and also expressed in meibomian gland and lacrimal gland. and also expressed in lens and ciliary body, retina, and optic nerve. Diquaphosphor stimulates water release from conjunctival epithelial cells. Diquaphosphor activates P2Y2 receptors and increase intracellular calcium levels. And the calcium activates calcium-dependent chloride channels to release chloride ion into tear film. After that, osmotic imbalances stimulates the water secretion into the tear film. And another function of diquaphosphor is promoting mucin secretion. In goblet cells, increase the calcium concentration via P2Y2 receptor activation promotes mucin secretion to the ocular surface by fusion of mucin granule to the cellular membrane. And in this study, it is observed that the instillation of diquaphosphor, the tear volume, was significantly increased in dry patients than normal saline. The effects lasted at least 30 minutes, and which indicates diquaphosphor can increase water secretion. And in lab model, treatment of diquaphosphor increased mucin secretion when compared to normal saline group. And after diquaphosphor treatment, mucin was significantly decreased under pus staining. It means mucin is secreted. These pinkish materials are mucin in goblet cells, and after application of diquaphosphor, the amount of the mucin significantly decreased, as seen in this figure. Dry eye destroys goblet cells and reduces mucin, but diquaphosphor can restore this deterioration. Diquaphosphor increases tear secretion and mucin expression, then stabilize tear film. And another thing is, recent studies have reported results supporting that diquaphosphor also promotes the secretion of lipid. Please look at this figure 1. You can see the released TG, which is a triglyceride lipid, increased as the incubation period increased after giving diquaphosphor. And also, it was identified that meibomian gland lipid droplet increased when the diquaphosphor was instilled in a mouse model, and you can see the lipid in this right figure. And even in the human patients, it was observed that the lipid layer thickness of the tear film was increased and diquaphosphor was applied. Taken together, these results suggest that diquaphosphor is also effective in patients with meibomian gland dysfunction. In addition, diquaphosphor can accelerate corneal epithelial healing processes. As you can see, these experiments, the authors observed the corneal healing improved in diquaphosphor-treated eyes than control eyes. In a nutshell, diquaphosphor can promote the secretion of water and mucin secretion as well as lipid on the ocular surface. Then this stabilizes tear film and treat various causes of dry eye. In addition, there is no definite instillation discomfort, so it is generally well tolerated. And diquaphosphor has a favorable safety profile. So therefore, diquaphosphor can be used as a backbone of dry eye management. Next, let's look at the actual clinical efficacy of dry eye diquaphosphor. In this study, the authors presented that diquaphosphor is effective in aqueous deficient dry eye. And as you can see in this figure, the cornea erosion is much improved after diquaphosphor treatment. And in this meta-analysis, decophosphor was more favorable than hyaluronate or artificial tears in Schirmer test and tear breakup time. And according to this study, decophosphor was also effective in short BUT type dry eye patients. And decophosphor also showed potential treatment outcomes on meibomian gland dysfunction patients. And this study also showed the lipid layer thickness of tear film was increased when the decophosphor was applied to actual dry eye patients. And decophosphor has advantages on management of post-operative dry eye. After LASIK, decophosphor showed better outcomes than normal hyaluronate. And add-on treatment of decophosphor on artificial tear also very effective. And after cataract surgery, decophosphor showed better results than just artificial tears in this study. And other studies also showed good treatment outcomes of decophosphor after cataract surgery. And finally, I want to introduce my recent study. As you know, preservatives in eye drops has harmful effects. In Korea, we have a preservative-free decophosphor, so I evaluated the effects of preservative-free decophosphor in cataract surgery taken patients. We divide the patients into 3 groups. First group used preservative-free decophosphor, and second group used preservative-containing decophosphor. And last group used hyaluronate as artificial tears. In this result, I found decophosphor showed better TBUT and OSDI than artificial tear hyaluronate, and the DEQUAS S, which means preservative-free one, were better than preservative-containing decophosphor. And same phenomenon were also noted in MGD parameters. Preservative-free decophosphor was best and followed by decophosphor and artificial tear. Taken together, we can think that preservative-free decophosphor can be a main dry eye therapy after cataract surgery. So let me summarize today's presentation. Dry eye syndrome is a disease that accompanies ocular symptoms as the homeostasis of the tear film is broken due to various causes. Tear film instability and hyperosmolality, and ocular surface inflammation and damage and neurosensory abnormalities is a key etiological factors. And two strategies which are the stepwise management and subtype-based management are very important in dry eye management. And the decophosphor is a drug for dry eye with a unique mechanism that stimulates secretion of water and mucin at the same time. And furthermore, recent studies suggest that decophosphor is also effective in meibomian gland dysfunction. So decophosphor can be used all types of dry eye. In addition, combination of decophosphor and hyaluronate and hygiene and anti-inflammatory agents can be used for better results. And lastly, preservative-free decophosphor can be more effective than a preservative-containing decophosphor. This is end of my presentation that I prepared. Thank you for your attention.
Thank you so much again to Santen for sponsoring this webinar series from the start. If you will recall, our very first ITV episode was also about dry eyes, and that was given by Professor Yokoi from Japan. We have really gone for full circle indeed. So for our question and answer, I will be joined in by one of our colleagues who will also be moderating the interactive part of our episode today to join us in our discussion. May I call on Dr. Keisha Dionco Lennon, also from the section of cataract and refractive surgery, and also one of our ambassadors for dry eye management to join me. Hi, Keisha.
Good evening.
Hello.
Right.
Good evening,
So during
Professor.
the break, okay. So during the break, we have actually collated some questions from the audience. So it's best that we get this ball rolling, right? So I think we will wait for the question to be projected. All right. So for the first question, for Professor Jun, are dry eye questionnaires useful in your practice to assess objectively the dry eye severity of your patients?
First of all, thank you for very good questions. As the diagnosis of the dry eye is composed by symptom and sign, we need both. So it is very important to measure the symptoms of dry eye, and of course, the severe symptom, the patient who has a severe symptom is usually has a severe dry signs also, but sometimes it can be different, but usually has a linear relationship. So I usually use the OSDI or speed score to indicate how's the patient's symptom, and then I use as the symptom score as the guidelining for what I want to treat, and I will do the what kind of drug do I need to do, and yeah. So I think the symptom is very important thing for treating dry eye patients.
In line with that, Professor June, since you said that we use actually subjective symptoms to assess the severity of dry eyes, and we have actually started to look at breakup patterns, right? We are shifting to a tear film oriented diagnosis already. So do you actually look at breakup patterns as well in monitoring improvement in your treatment for dry eyes?
Oh yeah, it's very good question. As the Dr. Yokoi published the paper, he classified the tear breakup time into 5, and I usually use that breakup time patterns for the patient, and actually little bit confused with sometimes with the linear break and random break, but I always very convinced in the spot breakup time. Yeah, that's obviously has the mutation deficient. So I usually use that that type of breakup pattern. So I usually use the mutation supplementary treatment. As you know that, as I told you before in this lecture, the dequaphosphor is very important treatment for mucin, and in Korea, this is the only treatment for mucin. But these days, as you know, the levamipid drug also is available in Japan and other countries. So that can be applied also, but these days the dequaphosphor is only treatment and very good option for those patients. And I usually see the some random breakup pattern, and at the time we have some cornea erosions inferior of the cornea. At the time it usually associated with aqueous deficiency type. So in that pattern, I usually use punctal plug or other tear secretion therapy for those patients.
All right. Thank you for that one, Professor. Trisha? I think you have the
Next,
Yeah,
I think we have a next question, ma'am.
yeah. I can see
Okay.
the
So
question.
okay. So for the second question, okay. So
Yeah.
are there any ancillary diagnostic tests that help with the TFOD, tear film oriented therapy approach?
Yeah, of course, the to distinguish which tear film layer is affected, I need to do several tests. I usually do in the when the patient first visited my clinic for the dry eye. I usually do several tests, including we have the keratograph 5M for micrograph and tear uh, non-invasive tear breakup time and the tear meniscus height. And these things are very important for distinguishing the which types of the which type of dry eye, and then which layer of tear film is affected. And then I usually do the lipid view test for evaluating lipid thickness, but it is usually affected by tear volume. So when I understand and when I express the to expressing of the to understand what the result is, at that time I need to think about the aqueous deficiency also. In aqueous deficiency patients, the lipid layer thickness can be very variable because the lipid can move with the water in the tear film. So when the water is decreased, the lipid cannot move smoothly. So at the time, even in the meibomian gland is bad, lipid layer thickness can be high value, has high value, can has. So in the cases, we need to very cautious about understanding what disease subtype, what dry subtype happen. And I also always do the, as you know, the SLEMP examination. And with the SLEMP examination, we can find very easily the which type of dry is the patient has, because I always see the meibomian gland, and I usually little squeeze of the meibomian gland. It's very helpful for treating when to decide that treating the patient with IPL or lipid flow treatment. And then if the patient has conjunctival erosions, at the time, usually the patient has inflammations. So in the cases, I usually use cyclosporin for the inflammation treatment and very short time of steroid.
Oh, okay. So it means that aside from the T4, from the breakup pattern, there are also additional ancillary procedures that you do to actually diagnose and then treat your dry eyes patients. Okay, I think we have some more questions coming up.
Okay, so Professor, for patients often noting stinging sensation when they apply diquafosol, do you have any useful remedies that you can recommend to prevent this?
Yeah, it's very good question. I also met many patients who feeling discomfort when applying the diquafosol. Previous studies said that the diquafosol can affect not only the P2Y2 receptor as well as the capsaicin receptor, TRPV receptor. That is kind of a pain receptor. In some patients, because of that situation, they feel discomfort on diquaphosphor. But in the cases, I think if the patient cannot tolerate the use of the diquaphosphor, I usually stop the diquaphosphor, because that's because of the receptor, pain receptor. So I think in the cases, we cannot manage the patient. But usually the patient does not feel like that. So I usually use the diquaphosphor in normal patients. And sometimes, as you know, after use of diquaphosphor, some patients have a symptom of a discharge, very high TCN discharge. At that time, I usually explain the patient the diquaphosphor's effect on that patient is very nice, I think. So at the time, I usually tell to the patient to lessen the. Usually, I use the 6 times a day, and I usually at the time I teach the patient to use 3 times or 4 times a day. And if even though they have symptom, and at the time I can change the drug, but I usually do like that.
Okay, thank you, Professor. Some of us, I think I don't know if you also try this in your hospital, but some of what I've heard from other consultants is it also works if you apply, for example, sodium hyaluronate, like a few seconds before you use the diquaphosol, just to act as a buffer over the cornea. It's one technique that I've heard from other cornea specialists.
Yeah, I think it's one of the good options, and yeah, but yeah, it's very nice.
All right. So I think we have another question. All right. So would you consider giving a low dose steroid eye drop along with diquaphosol as a first-line treatment already for mild to moderate dry eyes?
It's a very good option to use a steroid for dry eye very short time. Actually, I usually use the steroid for inflammatory dry eye type. So I usually use the steroid and cyclosporin, and I have a bridging technique for as you know, the cyclosporin has much more pain on when we instillation. So at that time, I usually use the steroid for 2 weeks, about 2 weeks for combination, and then I quit the steroid and use the cyclosporin alone. But usually in diquaphosphor treatment, I usually do not use bridging technique. I just use diquaphosphor for the patients, and I think most of the patients can adjust only when the diquaphosphor eye drops, and using the diquaphosphor eye drops without the steroids. So I usually do not use combination with the steroid and diquaphosphor.
Also, for mild dry eyes, Professor, in your experience, diquaphosol is already sufficient to address mild dry eyes. Is that correct? And then only for moderate or severe, then you can start on a bridging technique between your steroids and cyclosporine.
At the time, that means that as I told you before, I usually classify the subtype of the dry eye. If the patient with severe, but the patient has a little inflammation, and the main maybe if the main problem of the patient is aqueous deficiency, I usually use punctal plug or other tear secreting drugs, and I usually use the treatment depending on the patient subtypes.
All right, thank you. So I think, do we have any more questions for Professor Kish?
So, Professor, in your practice, in patients who have undergone ocular surgery, such as cataract or probably laser refractive surgery, do the tear breakup patterns end up changing or remaining the same? Would this affect your treatment?
Of course, and in my previous study, as you saw, I usually think about the importance of dry eye before surgery, any surgery, like including cataract surgery and reflective surgery. So I usually first treat the dry eye first before the cataract or reflective surgery, because after the surgery, as you know, we cannot touch the eye, and we just put on many eye drops with containing preservatives. So it usually worsen the dry eye after the surgery. I think it's a natural course. So I absolutely use eye drops and eye dry treatment before the surgery, and after the surgery, the main in my previous study, I found that main subtype of postoperative dry eye is meibomian gland dysfunction, because after the treatment, I cannot touch and we cannot wash my face, so the lipid cannot move freely. So it worsens the lipid gland and meibomian gland, and it usually arises the meibomian gland dysfunction. So before the surgery, I usually treat meibomian gland dysfunction very aggressively. And in last year, in Korea, in Samsung University, it's also in Korean hospital, they found that lipid flow treatment before the cataract surgery is very effective after the dry eye after the cataract surgery. So I'm very convinced to treat the dry eye before the cataract surgery, and immediately after the cataract surgery, as you know, we cannot use the wash or the warm compression and lid hygiene. So at that time, the dequaphosphor is very effective, I think, because when we put the dequaphosphor on the eyes, the lipid gland can be more smooth and can secrete more freely.
All right.
Okay, thank you, Professor.
Okay, I think we have answered everything. If there are no additional questions, we would like to thank once again Professor Ik-Hyun Jun for gracing us today. It was truly a pleasure to listen to your experiences regarding the backbone of dry eye management. 감사합니다.
Thank you very much. Thank you very much for inviting me, and it's a great honor to be here. I want to see you again in the personal meeting.
Sure. Thank you, Professor. So I think we have now come to the last part of our program, which is the workshop on dry eye management. So Keisha is here with us today to actually facilitate this very engaging and interactive portion together with Dr. Tina Tan. So the floor is now yours, Keisha.
Glaucoma is the leading cause of irreversible blindness, and cases continue to grow year on year. Most anti-glaucoma medications in multi-dose bottles contain preservatives, which could cause ocular surface disease that leads to deleterious outcomes such as reduced quality of life, reduced adherence to treatment, increased rate of surgical failure, and medication-related morbidity. But with Sunten's preservative-free glaucoma treatment, you could be the guiding star in your patient's journey. Start preservative-free therapy for naive patients who react badly to treatments with preservatives, or younger patients who require long-term treatment. Alter treatment by switching to preservative-free treatment for patients intolerant to OSD or have uncontrolled IOP under a monotherapy regimen. Replace treatment for pre-surgical patients to reduce risk of OSD and reduce surgical failure rate. Sunten's preservative-free Tufloprost and preservative-free Tufloprost Timolol fixed combination effectively controls IOP with high response rate, high tolerability, and reduced risk of OSD, making the treatment more comfortable and improving the quality of your patient's life.
Okay, good evening. Tonight, I will be reviewing with you a diagnostic and therapeutic approach to dry eye disease, which is the tear film breakup patterns. So now, to understand the mechanism of each breakup pattern, it's fundamental that we all understand the basics of tear film dynamics. Okay, so during eye opening, the capillary suction pressure from the upper meniscus pulls the aqueous tears upward, okay? And this results in the deposition of the aqueous tears over the cornea. Insufficient suction to pull the lipid layer upward results in a surface gradient between the two immediately after eye opening. So again, this is very important, this pressure gradient. The surface pressure gradient results in the upward spread of the tear film lipid layer, which simultaneously drags the aqueous tears upward. So the simultaneous aqueous drag is causing the aqueous thinning inferiorly because of the interplay of the suction pressure of the lower tear meniscus. So again, when the upward spread of the lipid layer occurs, there's an aqueous drag, again thinning out the aqueous. Okay. So once the upward movement of the aqueous and the lipid layers have stopped, the precorneal tear film is now established. And then this cycle is repeated with each blink. Note that any missing component in the tear film will affect these events, and this will be reflected in a particular breakup pattern. Now, we all have to bear in mind that breakup patterns actually occur at different stages in the tear film cycle. So to understand each pattern, it is very useful to answer these 5 questions. First, why does a particular breakup pattern occur? Second, where is it located over the cornea? Third, when does it occur in the tear film cycle? Number 4, what is the insufficient component and the corresponding dry eye type? And lastly, how is it best treated? So we begin again with why, where, when, what, and how. Okay, so this first breakup is called your area break, and this usually occurs due to severely diminished aqueous. So where does it occur? This breakup is generalized and occurs immediately after eye opening. So that answers your when. So again, it occurs immediately after eye opening. You have to note as well that there is no upward movement of the fluorescein due to the lack of aqueous, as seen in the video. So usually when there is enough aqueous, you will see a very thin greenish film moving up from inferiorly going upward over the surface of the cornea. Also notice that there is severe ocular surface damage as reflected by the punctate keratopathy, which is a key finding in this pattern. Okay, so this surface damage occurs due to the accumulation of inflammatory mediators from the lack of aqueous. It's also common to see a lot of mucus plaques and filaments. Therefore, as a problem of severe aqueous deficiency, this is best treated by your punctal plugs to preserve the remaining aqueous and supplementation with preservative-free lubricants. Okay, moving on to the next one. This is called a spot break, as you can see in the video. Spot break occurs due to mucin deficiency. It variably occurs over the cornea, and it immediately occurs after eye opening. So again, if you notice in the video, as soon as the patient opens his or her eyes, you can see spot breaks. Okay, so if you are asked, then the breakup time would basically be 1 second for a spot break. The spots are actually areas of lipid contaminated glycocalyx. So during the upward spread of the fluorescein, small spot breaks occur variably, and this suggests decreased wettability. And this is also best treated by a mucin secretagogue, such as your diquafosol. Okay, so the third breakup pattern is a line break, and this occurs again due to the simultaneous thinning of your inferior aqueous, as you can see in the video, and the upward aqueous drag. So as you can see, there are fine streaks of breakup over the thinner tear film inferiorly because of the lack of aqueous. So again, if you were to question yourself, you will see a line break inferiorly, and it also happens not immediately after eye opening, but during the upward spread of the tear film. So wait at least around 2 to 3 seconds before you can actually see a line break. So this breakup will suggest mild to moderate aqueous deficiency. Okay. Okay, next we go to your dimple break. So your dimple break is also caused by mucin deficiency. And again, if you ask where, this is found centrally or slightly superiorly at the thickest portion of your tear film. So if you see a breakup that occurs during the upward spread of the tear film and it occurs centrally, then that should be a dimple break. Okay, and this breakup should be reproducible for you to say that this is a dimple break. So it occurs because of decreased wettability as well, and it is best treated by your mucin secretagogues. Okay, finally, we go to the last major breakup pattern, which is the random break. And this occurs due to increased evaporation due to deficiency in either your lipid or your mucin. So by the name itself, it occurs randomly or variably over the cornea. And it's important to remember that if you notice in the video, random break usually occurs most commonly after the tear film has already completed its movement upward. But sometimes you can see it occurring during the upward movement. So it can either be during or after the establishment of the tear film. So again, this breakup will suggest your evaporative type of dry eye, and you can treat this by giving hyaluronic acid, your lipid-containing supplements, performing MGD therapy, and you could even give mucin secretagogues. Okay, so finally, in addition to the 5 major breakup patterns, there is actually a 6th modifier of tear breakup, and this is called the random expansion. Okay, so your random expansion will usually accompany your line break. So you can have a line break with rapid expansion, or it can accompany your random break. So it can be a random break with rapid expansion. So again, this is very important to identify because as soon as you can see a random expansion, this will immediately tell you that there is decreased wettability dry eye. Okay? So I've placed this summary slide for easier recall. So you can see here that the patterns in blue represent aqueous deficiency dry eye, which are again area break for severe aqueous deficiency, and mild to moderate aqueous deficiency is for line break. So again, those are in blue. Random break suggests evaporative dry eye, and patterns in red on the right side, namely your spot break, dimple break, and your rapid expansion as a modifier, correspond to decreased wettability dry eye. Okay. Okay, so in summary, we have discussed very quickly the 5 breakup patterns, including the significance of your rapid expansion. Again, if you answer these 5 questions, it will guide you in successfully applying breakup patterns in your practice. So later on, we will be playing a short game. I would like you to ask yourself 2 of the 5 questions. So when did the breakup occur, and where did you see the breakup pattern? Okay, so I'll close this set of slides first. So for us to prepare, I think we just go into a short break, and then we will prepare the slides for the game. Okay, so I think we're all ready to play the game. All right, so this is called the Breakup Challenge, brought to you by the Medical City Eye and Vision Institute. So this game was designed to test your knowledge on the tear film breakup patterns. So this game will be moderated by myself and my colleague, Dr. Christina Tan. So this game has the five breakup patterns will be discussed after feedback for each breakup presented. And you will see here that the game is divided into three levels. So level 1, 2, and 3, arranged by level of difficulty. Okay, so I think at this point we will just show you how you can join the game, and then when we have enough participants, we will already begin. And when we have enough participants. Okay, I was given a cue that we can start. Okay, now let's play. So starting level 1.
Hello, good afternoon. Hi, Doc Kish. Good afternoon to you. So, we will be presenting the first case. Okay, we will be giving you some time to think about the tear breakup pattern. Okay, time is up. So, can we show the audience our answer for this case? Okay, very good. So, the audience got it right. This is correct. The answer is spot break. Can we go back to the video? Okay, can we show? All right. So you can see in this video that the spot break occurs immediately after eye opening in areas where the surface wettability is impaired. So as Dr. Keisha mentioned, note that the spots should be seen consistently after each blink. And these are again caused by mucin deficiency, making it a decreased wettability type of dry eye. And as Dr. Keisha mentioned, the suggested treatment for this type of dry eye is diquafosol. All right, so we can now move on to the next case. Okay, so this is another pattern. Let's see if we can answer this one. All right, time is up. Can we show the answer? All right, very good. Almost everyone got the answer correctly. The answer is a dimple break. Okay, so as you can see in this video, this is a post-LASIK eye as outlined by the flap that you can see here in the video. So the dimple break forms after eye opening, and there is a deficiency of mucin in the interpalpebral or central area. So when the eye opens and the tear film spreads upwards, the dimple break forms over the area of decreased wettability. And as mentioned by Dr. Keisha, the treatment is also diquafosol for this type of dry eye. Okay, we can now move on to level 2. I'm sorry, this is the last case of level 1. All right, so can everybody answer? Okay, time is up. Can we now see what everybody answered? All right, very good. So almost everybody got it correct again. The answer is a random break. So as mentioned by Doc Keish earlier, the random break happens after eye opening and after the cessation of the upward movement of the tear film. So this is usually from a deficient lipid layer causing evaporative type of dry eye. So the treatment will include your lipid-containing drops, sodium hyaluronate, or diquafosol. All right, so this concludes level 1. Let's move on to level 2, the moderate round. Okay, can we all send in our answers for this case? Time is up. All right, let's show the answers of the audience. Very good. So almost everybody again got it correctly. The answer is an area break. So as you can see in this video, the area break happens after eye opening, and there is no upward movement of the tear film. You can also note that there is diffuse punctate epithelial erosions, which indicates a severe type of aqueous deficiency. So the treatment, as mentioned previously, includes your punctal plugs and preservative-free eye drops. Let's move on to the last case of the moderate round. Okay, so can everybody send in their answers? Okay, time is up. Let's show the audience's answers for this one. Okay, so it's 50-50. 7 people answered line break and 6 people answered spot break. So let's show the answer. So the answer is a spot break. Okay. So this is also a spot break pattern. What's interesting about this video is the presence of grade 3 conjunctival chalasis inferiorly. So as you can see with the conjunctival laxity, the corneal surface is not smooth, and this increases the incidence of decreased wettability. So treatment would include your conjunctivoplasty and in conjunction with your diquafosol eye drops. All right, so this concludes the moderate round. I'll be turning over the session to Doc Kish for the last round.
Okay, thank you, Tina. So we will move on to level 3. Okay, so for level 3, there will be some videos where there are several breakup patterns, but you can answer whatever you see in the video, and I will just show which is the most predominant. Okay, all right. So for number 6, here is the video. Okay, I think the time was almost up. Let's show the responses. Okay, so everyone at least keyed in rapid expansion. Someone answered line break, some answered dimple break, and the minority answered random break with rapid expansion. Okay, so actually this video is a random break with the rapid expansion. So it is actually a combination of both, because you'll see that some line breaks occur but they randomly expand, and some dimple breaks occur but they also randomly expand, and that therefore makes it a random break. So you can see that the breakup is not uniform, not only happening inferiorly, it also doesn't happen centrally, just centrally. So again, if I play the video, okay, you can see that the breakup actually occurs in several areas and then it rapidly expands. So you can see a connection between the different areas of breakup. Okay, so while you might see a break centrally, there are also breakups superiorly. So again, it's a random break with rapid expansion. And this type of breakup pattern, again, if you have a modifier such as your random expansion, that will automatically be a decreased wettability type of dry eye. Okay. Okay. So let's move on to the next. Okay. Here's our 7th video. I'll play it again. Okay, now I have the results. Okay, so majority answered line break, so that's very good. Okay, thank you. So this is a line break again. You can see that after eye opening, during the upward spread of the tear film, the breakup occurs inferiorly, specifically forming streaks. So again, this is a line break, signifying mild to moderate aqueous deficiency. Okay, very good. Okay, now we will move on to the 8th question. Okay. Wait again. Okay, I think we can now see the answers or the responses from our players. Okay, so I already saw the responses. Majority answered spot break, okay, and dimple break. Okay, very good. So actually you can see two types of breakup patterns here. Immediately after eye opening, you can see a spot break. So as our speaker said earlier, it's really not difficult to notice a spot break, no? Now you can see as well your dimple break. Again, let me play that again. As the upper spread of the tear film occurs, there is a breakup centrally near your spot breaks. Okay, so again, both spot break and dimple break are both pointing to decreased wettability, dry eye. Okay, so let's go to the 9th breakup pattern. Okay, I think time is up. Let's check what you guys responded. Okay, so majority answered line break with rapid expansion, followed by spot break. So let's see. Very good. So the predominant breakup pattern is truly line break with rapid expansion. So it happens inferiorly, and then you can see the inferior breakup rapidly expanding. Also, in the next few blinks, just wait for the video Okay, you can see a spot break. No, so this is a combination type of breakup, both pointing to decreased wettability dry eye. Okay, so we see a lot of this actually in the dry eye clinic. Okay, moving on to our last number. Okay. Okay, time is up. Let's see our responses. All right, so there's a tie between spot break and line break, and then followed by dimple break. So let's see if those are correct. Okay, great. So I think everybody's getting a hang of this already. Very good. So the predominant breakup pattern is your spot break. So let's watch that again. As you can see, even in the there you can quickly see it. And there's also a line break because there is an inferior breakup. And finally, you can see as well a dimple break, during the upward spread of the tear film as it occurs centrally. Okay, very good. Thank you to our players. So you've completed the breakup challenge. We wanted to make this fun because we wanted to break the bias when it comes to breakup patterns. So I know it's not as easy to apply in your practice, but when you do it regularly, actually when you take the breakup time, you immediately see the pattern. So it's not something that will cost you additional time with your patient. So you can actually incorporate it easily as long as you practice it. Okay. So some practical tips before we end this review and this breakup challenge. It's very important that you practice the proper technique. And here are some musts when you perform your breakup patterns. It's very important that you use BSS. Avoid using alkane or your proparacaine when you do the breakup patterns. You have to make sure that you're not increasing the tear volume of the patient, and you can do this by shaking off the fluorescein strip of excess fluid, and also by lightly touching the central lower lid margin of the patient. So avoid painting the conjunctiva with the fluorescein strip. Also, it's very important that you clearly instruct the patient what to do. So what I usually tell the patient after I lightly touch the fluorescein strip on the central lid margin, I tell them to blink several times and then ask the patient to briskly open the eye. So as you can see in all of the videos, the patients were instructed to open their eye quickly. Okay, that's very important because that's when you will see the true pattern of the tear film breakup. Finally, it's very important that you do it at least 3 times. So the pattern should be repeatable. And this will tell you that the breakup pattern that you have seen will really point to the true underlying pathology or underlying mechanism of the dry eye of your patient. Okay, so thank you for joining us in this game, and we hope that after playing this breakup challenge, you will try to apply breakup patterns in your own clinical practice. Okay, thank you very much.
Okay, so thank you, Kisha and Tina. And thank you, everyone. We hope you enjoyed this refresher episode on dry eyes diagnosis, breakup pattern identification that will help you in your tear film oriented treatment. So once again, we would like to thank Professor Jun for his very informative lecture. A big thanks again to Kisha and Tina for facilitating the Dry Ice Workshop. Of course, to Santen, our sponsor for this episode, and to all our viewers for your continued support as we go 3 seasons strong. So this is Marga Mejia from the Medical City Eye and Vision Institute signing off until the next TMC ITV episode, your ophthalmic instruction without borders. Good night, everyone.